Thanks, Doc, for joining us. Good morning. Unmute.
Very good.
Good morning. Happy holidays.
Yeah,
Happy
morning, morning.
holidays.
We'll just go and throw it over to you. I know Jason said you had some slides. Okay. Yeah. So again, Dr. Peter Lombard, he's been a regular way back since the show was called Containing COVID, and I was almost going to say we like his perspective, but it's really just data driven and looking at numbers. So I'm not even sure if that is even a perspective. It's very objective, Dr. Lombard. So go ahead. I know you got some slides. We'll just give you the floor, and then we're going to shoot a bunch of questions at you after.
All right. Sounds good. You guys are ready for some more boring slides. You're not done with COVID.
It's slide day,
No.
not Friday.
Slide day.
Well, I appreciate you guys, everything that you do. It's really impressive to see you bring in so many different disciplines. And I wish I could watch you every morning because, a lot of great information gets passed that you wouldn't be able to find anywhere else. So thanks again for everything that you guys do. Just to start off with, you can look at the Thanksgiving effect on mobility in Guam, and it really didn't do much at all. That's just driving data. So, it doesn't say a whole lot other than we didn't have mass amounts of people outside driving. But, on the holiday in general, you don't see as many cars on the road. So I'm not sure that that's indicative of much. It certainly doesn't tell us how big a family sizes we're getting together. I've asked all my patients this week, and all of them said it was a very subdued Thanksgiving. So from that perspective, I think that bodes well for the effect of Thanksgiving, and I think that's what we're seeing in the cases so far. In the U.S., of course, I think that's very different. I think a lot more people were on the roads. Flights were up for sure, and in the U.S. situations we talked about last time I was on, it's looking very, very dire. They're approaching 3,000 deaths a day. I think today they had it surpassed the number of people that died in 9/11, and every single day. And that's just an astounding number. We went from about 5-6 weeks ago being in the top 5 in the country in the number of new cases per day. Now we're in the bottom 5 of the country. You can just see because our numbers have gone down, and the rest of the U.S. states, they've been slowly increasing over the past couple of weeks. It's just been a dramatic reversal. So they've got a lot of work to do, and we're obviously very grateful for where we are, but it came at quite a cost for us. This, just to throw this up there briefly, just a reminder of the CDC travel guidelines. The green line is what the goal is: 100 cases over 28 days. We'll have to be at the level of 2 to 3 cases per day, and we're around 30 right now, and sustain that for weeks before we ever get out of the level 4. So just a quick reminder about that, and I don't think it's something that we actually really need to pay attention to for quite some time. So here's a little bit of a breakdown. I know you're talking to Dr. Pobutsky about this. So this is last week ending Friday, not this week, but last week you can see a tremendous decrease in the total number of cases that we had, but also in those age groups that we really care about, 90 plus, 60, 70, 80, 90. That's really squashed down tremendously. And so those are where most of the hospitalizations, and if we're going to get deaths, that's where they're going to come from. So I think that's why we're seeing fewer hospitalizations and fewer deaths, fewer cases, fewer hospitalizations, fewer older people getting this, and fewer deaths. It all is going and making sense. Now remember, the cases from 2 weeks ago are the ones where we're going to see the deaths. So these elderly patients down here are the ones that you have to do the analysis on to say how many of those might turn into deaths. And I've been tracking that, and the blue line is what my prediction had been. And early on, it was tracking really well. And there's been a divergence recently in terms of the actual deaths. And this 112 is actually gonna flatline out to today, really. And that's a really huge divergence because we've had no cases, which is wonderful news. Now, why did the prediction, the equation, why was it doing so well before, and now it's not really predicting things as well anymore? I think there's a few reasons for that. Whenever you're dealing with higher numbers, there's less noise, and then you get the true statistical data out. Because I'm using these IFR estimates based on each age group. So I look at how many patients are in the 80 to 90 age group, and I apply a very specific infection fatality rate of 10% to that. And I'm also doing a prevalence estimation. So if we have 5 cases in that age group diagnosed, how many do we really truly think are in the community? So there's another adjustment there that you have to multiply. So that, again, it worked remarkably well for, gosh, almost 3 months. And now there's this divergence, I think, because of the relatively low numbers that we're seeing now. But there could be some other things. I think that there's quite a possibility that we're misattributing some deaths that are actually COVID deaths, or we're just not picking them up for some reason. And when we look at the excess deaths a little bit later, I think that's more evidence that that's probably happening out there. We're also probably able to take care of our sick patients better because the hospitals are not as overwhelmed as they were a month or two ago. So that might be playing a role in why our deaths have declined. Now, there are, 10 people in the ICU and 6 or 7 or 8, something like that on ventilators.
Right.
So, I don't think the mortality is much better than, 30-40% on the ventilators now. So, unfortunately, we're still going to see some. But if we can get down to 1 or 2 deaths per week instead of per day, that's tremendous. And by the end of the year, hopefully we can keep the total number less than, say, 125, 130, where initially we were looking at, an estimate maybe 150. So that's good news for what to expect in terms of our deaths. Now, I did a quick update because I think Public Health finally released the September numbers. They're pretty delayed. The September total deaths in Guam. And if you extrapolate out to the end of the year with a reasonable estimate, we're looking at seeing about 1,150 total deaths in Guam by the end of the year. And that's just going to be total people that die. And that's not to say how many of those are COVID deaths, doesn't matter. That's what we're going to see. It's going to be somewhere around there. When we're expecting, if we follow the normal trend over the past number of years, to be around 900. So that's about 250 extra deaths that are happening in Guam this year that have come from somewhere, right? And how many COVID deaths do we have? We have 112 documented. And where are those other extra deaths coming from? Are they caused by COVID that we're just not catching them somehow? Or there are secondary effects of the lockdown that people are worried about. So these are important, I think, and interesting things to try to look into and try to figure out what's happening. And so that also makes me wonder, because when it comes to the predicted deaths, I feel like they should be a little bit higher, but they're not. When it comes to the actual data, maybe there's some other deaths out there that are not being reported as COVID deaths. But I certainly don't think we're undercounting deaths, which has been overcounting deaths. I think that the data clearly shows that the COVID pandemic is causing a lot of extra mortality in Guam and elsewhere. Now, this isn't what we're seeing in every country, though. Some countries are actually showing it a flat line or even a decrease in extra deaths, but I think there's other reasons to explain that too, and we've talked about those before. Right. Less respiratory illness, less influenza deaths, less people out on the roads, less car accidents, and so it becomes a little bit of a complicated picture if you're trying to just only look at excess deaths to try to figure out how bad things are where you are. I wanted to touch briefly on the vaccine because, I appreciate you guys giving me a bit of a platform, and I don't know how many people we reach out there. I try to be very factual and level-headed in the things that I say. From everything that I've seen and study, and I try to pick and choose the people that I follow very carefully. I think this is really excellent news on the vaccine data, and I'll be, the first one to put my hand up and say I can't wait to get my vaccine. And there's a lot of confusion, a lot of maybe apprehension about this vaccine. The mRNA method of vaccine is still pretty new. It's only been used for the past 3 or 4 years, but it's been used before the COVID, so it's not the first time. But, if you look at the sample sizes in the first 3 vaccine trials that have been reported for phase 3, over 100,000 people in the trials, and half of them have gotten the actual vaccine. And there's been no serious adverse events in over 50,000 people who actually had the vaccine injected. Now, about 30,000 of those was the mRNA. The AstraZeneca trial was 20,000, but that's actually an adenovirus vector. It's not an mRNA, but still, if we're going to be seeing the mRNA vaccine coming here pretty soon, that's 30,000 people who got it and 0 serious adverse effects. So I think that's really strong data to say this is safe. All they're doing is injecting some RNA, which are little strands of DNA. They get into your cells. Your cell makes this little protein, this little spike protein. It doesn't make the whole virus. It just makes a little part of the virus. And that viral particle is the part that allows the virus to enter your cells. So your body sees this little spike protein floating around and it says, hey, that's not normal. it starts making antibodies to it. So all of a sudden you build up a robust antibody response only because you're produce some of these spike proteins, and it's actually going to be more effective than your own body fighting mounting an immune response to getting the actual infection. And that sounds counterintuitive to a lot of people. They say, well, let your body do the work, let it get the virus and fight it off, and you're going to be in better shape in the long run. But there's a lot of data that shows that that's just not true. The vaccines will give you a more robust and long-term response. And with respect to COVID, I guess one way you can look at it is when you get exposed to COVID, your body has a number of different ways they can fight it off. And some people fight it off without even ever mounting an immune antibody response. I think you've heard of T cells before. Your T cell response could be so strong that you fight off the infection before it ever gets to the level of needing your body to mount a significant antibody response. So, when you're exposed to it, your body has a few different ways to do it, but in the long run, you're not building. Probably the best way is to have these antibodies circulating that have a memory. So if you get exposed in the future, they can rapidly mount a response again. So it's a very specific and targeted way to build up your immune response. And I just haven't seen anything really negative other than mild side effects, which, we would expect that with any vaccine. But I hope if I can say anything to alleviate people's concerns, this is my shot to do that. And this is really going to be a good thing. And it's what we need to get us back to some sense of normalcy. But as Dr. Butsky said, it's still going to take some time to get enough people vaccinated. I've been doing this prevalence calculation. I think we're probably around 30% of people in Guam have been infected to this point, somewhere around there, plus or minus. And more than anything, I think that's the reason why we've been able to bring our numbers down. Because over the last 3 months, you saw it on the mobility data. And also, I think if you just look at how long we've been in peak core 1, the policies haven't changed, the mobility hasn't changed. The only thing that's changed is the number of people out there that have been infected to this point. So I think it talks again to the point of the number of susceptible people walking around is just much less. So it really is difficult now to have another surge. And I hate to go be too bold, but I just don't think we're going to have another surge like we did before if we just keep doing what we're doing. Okay, I just don't think it's possible because there's not enough people out there that are susceptible. And there's enough people still doing the right thing. To Chris's point, I don't, at least talking to my patients, a lot of vulnerable elderly patients, they're all still doing what they're supposed to. None of them are saying, oh, we've got this thing beat. They're all just going to bide their time. And I think they see that the light's at the end of the tunnel and that it just sticking, continuing to do what they're doing for a little bit longer is all we need. And we're going to be through this. It did come at quite a cost, though. 112 deaths is a lot. We were overrun in the hospitals, but we're definitely at a point where I think we have a lot to be happy about. Interestingly, if you look at the blue test, the blue line here, those are our daily positive tests. That overall curve, if you look at the CAR score, the curve of the CAR score looks almost identical. So from the standpoint of redundancy, for anybody that doesn't like the CAR score, if you want to just follow the 7-day curve of daily positive tests, and it's going to look very, very similar. And I think that's because it's one of the more important parts of the CAR score. And we still have to get down into this level. If we ever get down into the 3 to 5 cases a day, I said I don't think we're going to have a surge, but what we could do? We could do to try to prevent another significant surge is it seems like we're getting the test piece ramped up with the antigen test, but we could really bolster and augment our contact tracing while the number of positives is going down. It's something that we should have done in the summertime. We could have had 10, 20, 30 more contact tracers, and maybe if you had those extra bodies, we would have been able to blunt the surge that we saw earlier at the end of the summer and into the fall. So I don't, if you look at the antigen test that we've done in the last 2 weeks, remarkably, of all the positive tests that we've had, I think it's less than 5%. So they're not contributing a whole lot right now. The numbers are going down no matter what. So at this point, it would have been a lot more useful, I think, as we were having the surge happening to identify more people quickly. To get them to isolate. At this point, it's not as useful, but it will be certainly useful to help prevent any future mini surges or flare-ups. So that's it in a nutshell. I'm sorry to bore you again. I hope it's you guys find this useful.
No, we do,
you guys
Doc.
have any?
That's why we keep asking you on.
Yeah, I did have a question regarding what you were mentioning about the vaccine. And so, what about people that probably shouldn't take the vaccine?
More specifically,
Like
I'm sorry, I'm not
if
sure.
there's
I know
certain
we're-
health conditions or pre-existing medical conditions that it wouldn't be recommended for use.
Well, it hasn't been
it's-
tested yet in kids. It hasn't been tested yet in pregnant women yet. So those are two categories where
Okay.
that we're still waiting for some guidance. But I don't think there's been a couple trials that have actually enrolled kids and pregnant women. So as more data comes out, and you still got this Johnson & Johnson trial that hasn't been reported yet with even a bigger sample size. So I think those recommendations will come out at least for the initial, the first vaccines that we're going to get. We'll have to just stick with the recommendations from the types of people that they tested. I'm not sure if folks with autoimmune deficiency, things like that, that may be restrictions. I'd have to look at that. That's a good question. And I can try to look into that.
But you said that there haven't been trials on children. Is that what you said?
No, not to my knowledge.
Okay.
And I think that there may be arms in some of these other trials which didn't include children, but I'm not 100% sure.
Yeah.
All right, Doc.
Thanks, Doc.
Appreciate your time. Hey, give us a couple of those iced coffees when you get a chance.
Thanks, will do. Have a good weekend.
All right. Yeah, he likes that black, Mr. Brown. That's got some kick in it. See you, Doc.
Stay safe.
Take care.
There you go. Good talk there with Dr. Peter Lombard. He had said briefly talking about not anticipating another huge surge like we just had because I guess mathematically he said there's not a lot of people going around.